happy baby. You'll find that out later. But as a fetus, we call it attitude. And it has to do with the parts of the fetus related to itself. And there are really two things. They're either flexed or they're extended. Flexed or extended. What is a normal full-term fetus and newborn? Like they're in a flex position. So who's in the extended position?
Preemies.
Preemies are, absolutely. So that's what that means. That's flexion, and I don't have extension, but just know it exists. Now we have fetal presentation. So we have fetal lie, fetal attitude, either flexed or extended. I don't know why I don't extended, but I know. Then fetal presentation. Fetal presentation means what fetal part is presenting in the pelvis first. So that's how you can remember it. Presentation means what fetal part is presenting in the pelvis first. 97% of our deliveries will be cephalic presentation. That means they're what? Head down. Okay. 2 to 3% will be in the breech presentation, and less than 1% will be shoulder. That's the easiest one. The shoulder presentation is transverse.
What was the percentage on that?
Breech is about 2 to 3%, and shoulder is less than 1. So really, when we have a shoulder presentation, it's this shoulder that kind of falls down into the pelvis first. So in reality, they're not laying stiff as a board across the uterus like that. They're all folded up, and then all folded up, and then the shoulder will be down in the pelvis. Okay? So transverse is really a shoulder presentation. So you see, if you were to palpate in there, that's the shoulder. Okay? That's going to be a cesarean first. So for cephalic, though, we have some different changes to the head that will also affect. The best presentation to have to deliver a fetus vaginally is vertex. Vertex cephalic. Vertex means that this head is in the flexed position. Okay? Everything, those 4 words, vertex, military, brow, and face, have everything to do with what is happening to the neck. Okay? So, optimally, we start out flexed. Why? Because, again, it puts the smallest part of the baby's skull into the pelvis first. And that's good. Okay? So, flexed and head down, or vertex cephalic, is the best way. Now, as we move down our list, military, how do you stand if you're in the military? Straight up and shoulders back. Well, that's exactly what happens here. Straight up and shoulders back. So this is in, I'm not even sure what position that's called. Is that like just natural? Because nothing's happening to the neck. It's just normal or natural. This is, the neck is flexed here, right, in a vertex. Here, just straight up. Now we begin the extension process. In a brow presentation, the neck is flexed a little bit so that this is what's presented into the pelvic cavity first, the brow. That's why it's called brow presentation. Get in there. It's kind of hard to do in here. But brow. So if we're feeling and doing our exam, this is what we'll feel right here. We'll feel the brow of the baby. Okay? Which feels different than the back of the head, because what do we not have on the brow? We don't have a fontanelle. We're feeling no fontanelle here at all. We might feel a suture line, but that's all we feel. Or we might feel the anterior if we can get our fingers up there. And then the facial presentation is just complete extension of the neck. So this is how they look, and that's how they're presented in. So when you do your vag exam, you're poking eyeballs, nose, a mouth, okay? Very different. Now, a fetus can be born in the face or brow or military position, but only if it's a small fetus and a pretty amazing bony pelvis. Otherwise, they're going to probably be delivered by cesarean, because even though they may dilate in a face, they're not going to descend. And so the fetus will not come down into the birth canal, and that's necessary. So really, cephalic vertex is the only one that you'll probably see delivered vaginally. As soon as these presentations are discovered, they'll go for an alternate form of delivery. Okay? Breech has to do with, now, so breech, there are several different kinds of breech. There's frank breech. This is a breech, so what do you think we're feeling there? But we'll also feel a bony prominence here, and that's the sacrum. Okay? So their legs can be up like this. See how the hips are flexed, but the knees are extended, right? Their legs are straight and just folded up here. When they are born, they literally will lay like that again. You put them down to measure them, and they go boing, right back up like that, because their tendons and muscles have been stretched, and that's how they're going to be. And sometimes that can be several weeks after delivery. We usually just have to double, triple diaper them, and that'll put enough weight on the front of their thighs that'll push them down. But otherwise, they're kind of cute because they just go boing, and you push them down. But that does not have anything to do with congenital dysplasia of the hip or anything.
Did you say the knees were flexed as well?
No. In this one, the hips are flexed, the knees are extended.
And that's
And
in the
full
front.
frank breech. Full breech, hips and knees are flexed. So hips and knees are flexed, but their bottom's like this. Okay? If they have a footling breech, obviously if that footling comes out and during the process of labor, this is an emergency. This is like an obstetric emergency. Run to the OR and remove the child from that. Okay? All right, so those are the different presentations. Now, just another picture of what you might see, like complete flexion. So this is vertex, complete flexion of the neck. So again, when we do a vaginal exam, we're going to try to locate that small posterior fontanelle. As they have, this is a military presentation, oh, so they call it moderate flexion. Okay. Didn't know that word myself. Then we're probably going to be palpating the anterior fontanelle. And that's how you'll know the difference. And now not only are we finding the anterior fontanelle, but the brow, and here we're doing facial features. And pretty much military brow and face are going to be delivered how?
She's like,
Yeah. Okay, and there's frank breech, full breech, shoulder, transverse lie.
front will also be a section.
Huh?
The breech front. The breech front, all the breeches will deliver C-section.
Well, they're not in reality, but yes, they are. In theory, all breeches in this country anyway are delivered if you know about it ahead of time, and if you have time ahead of time. And now why do we get concerned about a breech? Why do we care if they come out feet first? Think about the question on your quiz today.
Because their head could get stuck.
Because why?
Oh, breathing.
We feel nothing reassured when this fetus is out like this because the biggest part has yet to pass. And remember, if you have seen a cesarean yet, who did that the other, you did, I know in my group, who did that the other day? You did, Jonathan? It's not easy sometimes to get them out, is it? Especially these fetuses who've been pushing, their moms have been pushing them in the pelvis for 2 hours, push. You don't just go in and say, oh, we're going to get it out. It's life-threatening to go in and now get them out. So we prefer to have the biggest part of the fetus come out first. Now, there are some small fetuses and some really big pelvises, and they deliver breech by accident or nobody anticipated it or whatever, and they're fine. but the risk and liability is high, and we're in a very litigious country and society. So if anything goes wrong to anything, we're all gonna sue somebody, right? I saw something on the Facebook yesterday when I was on that somebody is suing those people, Chip and Joanna Gaines, because their house is in a bad neighborhood. The house they redid for them in Waco, Texas is in a bad neighborhood.
What?
And I'm like, they didn't go there beforehand? They didn't see what neighborhood they were in? I don't know if it's a bad neighborhood or not. I would assume it probably is, but who knows? So I'm just saying, it's kind of weird. People will sue you for anything. We've had students threaten to sue us for a variety of things. Has not happened yet, but it's a possibility. I'm trying to decide if we really. Those of you who've taken HESI, were there any questions on fetal position?
No.
Because it's kind of a complex conversation. Pardon?
I didn't have any. I don't remember. I didn't have any.
I'm just thinking it's a little too detailed for us to worry about. Fetal position has to do with where the parts of the fetus are in relationship to the mother's pelvis. I really don't think we need to know that. Gosh, I hope you don't get an next question. I really don't think you will. Now, as far as presentation, see, that's different. Position and presentation are not the same thing. Presentation, sure, we need to know that head down and flex of the neck, vertex, that's good. When we hear that, we're like, oh, that's good, that's going to be a vaginal delivery. But not always, sometimes it's not, but you know, that would be advantageous anyway. So presentation, I think we should know what presentations are, okay? We should all know what these are and what they look like. But I'm going to make the big jump here, and I'm going to say we're not going to study fetal position. If you want to study it, if you want to know what it is, come to my office, I'll teach you, I have no problem with that. I know how to do it, I'm very familiar with it, but I don't think for a basic graduating nurse it's necessary. So there we go. I'm going to tell you here on normal labor, theories of onset. Really, what do you need to know? You need to know their theories. Does it say a theorem? We don't know why we go into labor, on our own, spontaneously. Nobody knows. There are theories, and that's probably all you need to know. We don't know. We know God, Buddha, and Mother Nature, Yahweh put us from the first day of our last menstrual period. How many weeks to term? 40 weeks to term, 38 to 42, but our due date will be 40 weeks. We know at about 40 weeks, most women will deliver. Okay? Things happen in their body. You can, if you're interested, you can, one of the things that happens is progesterone decreases. And that might be okay if we knew that, because what happens, what does progesterone do in the beginning? Maintains the pregnancy by keeping the uterus relaxed. So when near the term, when progesterone, and this is a documented fact, we know this happens, but is that the only thing that causes labor? Probably not. But towards term, progesterone begins to decrease. These other little things, prostaglandins, begin to increase. These cause contraction. Even during your menstrual cycle, they cause uterine contraction. So they can be pretty gnarly, okay? So between relaxation and something to cause contraction, that probably stimulates labor. But that's all we're going to do, okay? Okay. Here are the premonitory signs of labor, or the signs and symptoms that labor is going to come. Some women have them all, some have some, and some have none. So Braxton-Hicks contractions. What's the difference between a Braxton-Hicks contraction and a real labor contraction? Braxton-Hicks contractions do not change the cervix. They do not cause effacement or dilatation. Can they be painful?
Yes.
Yes. Can they be regular?
Yes.
Yes. Can you see them on a fetal monitor?
Yes.
Yes. Yes, you can. But they don't change. So knowing that, what we usually do with Braxton-Hicks is give the patients parameters of if the Braxton-Hicks change, so they get closer together, stronger, more frequent, or if your membranes break, or if they last longer than X amount of minutes, then you notify your healthcare provider. Because I just told you, they're painful, you can palpate them, you can see them on the monitor, but they don't change the cervix. How will we know if they change the cervix? You're going to have to do a vag exam, either digital or a speculum exam. Can mom do that?
No.
No. So we need to give her some parameters because at times women are in preterm labor, they think they're having Braxton Hicks because they forgot those little things. Oh, well, this is getting worse. Braxton Hicks don't get worse. They can be a little bit painful, but they're not like, oh, you can usually talk over them. They're not severe, okay? And they don't get more severe. They just stay the same. But the risk of Braxton Hicks, the real, as far as I'm concerned, the importance of them is they need to know when is that not a Braxton Hicks and you need to call us because you might be in preterm labor. Sometimes preterm labor takes several hours to determine. And we can't expect our patients to figure that out at home because we have all kinds of technological equipment that they don't have. Lightning? What is lightning? When the baby drops. That's the lay term. Sometimes your friends, family, neighbors will say, oh, you're going to deliver soon because your baby dropped. Okay? Is that accurate? Probably. Probably, but soon is a relative term. Could be 2 weeks. Increased vaginal discharge. As labor begins, what might you see in the discharge? A little bit of blood, a little bit of show. That just means a little bit of blood-streaked mucus. Frank bleeding is a 911 call. Okay, that's not a premonitory sign of labor. But a little bit of blood streaked in the mucus means that the capillaries in the cervix, as it's opening, are breaking, and so you get a little bit of blood. Not blood vessels, but little capillaries. Well, they are blood vessels, the teeniest of all. So bloody show can be normal. Frank bleeding is not normal. A spurt of energy. Sometimes women who are pregnant in near term, they get that spurt of energy, do those last loads of laundry, paint the rocking chair from their childhood, get the crib up, you know, bake some casseroles or whatever. They just zizz, 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 zizz around, okay? And that's kind of normal. For us, we need to tell patients to tender that with, you know, rest. You can't be up all night long if you're not a night worker. I mean, you need to still go to sleep, okay? So you stay up all night and you go later the next morning, it's going to be really rough.
Would that be pretty much like that same spurt of energy when you're premenstrual? Because that's hormonal.
I'm not really sure what the spurt of energy is caused by for labor. I'm thinking, what is that called? Caused by just a sense of... I'm trying to think, do people get a spurt of energy when they're premenstrual? I'm thinking I just want to lay on the couch or whatever. Take some Midol. Okay, small weight loss, so your book says. One more that is not on this list that you might hear is the stools get loose. And I don't mean raging diarrhea or watery stools, but they're loose. And this, actually, Angie, you might see in your premenstrual period. And that's from the prostaglandins that are released premenstrually, as well as with upcoming labor. So it not only contracts the smooth muscle of the uterus, but also of the gut. And so it moves through a little faster. Again, not watery, explosive diarrhea, but just loose stools. So I'm not really going to teach you this, but I'm going to tell you, you need to study this. There'll be 1 to 2 questions from this section in the book. 329 in your book. Sonia, why are you still here?
I'm waiting for my children to get.
Oh, they're not here yet. They have not
Yeah.
forgotten you.
Oh, that would be all right. I would miss your lecture.
Well, I wouldn't think that would be all right. Okay, so look at that chart. Maybe it's not a chart. Is it in the chapter?
Yes, it is. It's not,
Is it a chart? It's bulleted, yes?
yeah, it's not have a number now. It says patient-centered teaching, no, I don't know whether labor is.
No, it's bullets. It's bullets on the right-hand side.
I thought you were going home. Sorry.
Oh, yeah.
No, I was gonna, I thought you needed a ride.
Oh, no, it's there. It's patient-centered teaching on page 349. How to know whether labor is real. Look at those and see. You're
You're talking about the blue one, right? The blue
True
squares.
labor differs from false labor in 3 categories, by the contraction, the discomfort, and the service. Be familiar with that box, I'll probably take at least 1, maybe 2 questions from that box. 3? Okay.
Which box?
Page 329. Oh, page 329.
Okay, skip that because we didn't do it, okay. Why don't we take like a 15-minute break and then come back? We have a lot of questions.
There's one to check. There's one to check.
Got your thing, I'm gonna.